We know that CBT is extremely effective in the management of chronic pain. Yet anytime you refer a patient to a psychologist, they may say to themselves, yet again, here's another doctor who thinks that it's all in my head.
They feel it's dismissive somehow.
Exactly. So how do you think it's best to present the idea that CBT is going to be very effective to them, at the same time making sure they don't hear this as another doctor telling them it's in their head?
So this gets to the heart of medicine, I think. We start with empathy. We start by validating their experience and helping them understand that we're not dismissing them at all. In fact, we are taking their distress, their suffering, quite seriously. And we help them understand that we wouldn't be having this discussion if strategies that we'd used in the past or other docs had been effective. So we talk with them and empathize with them about their experience. And then we normalize the process of CBT. We help them understand that, as you pointed out, CBT has been demonstrated to be effective, that we are routinely referring our chronic pain patients to CBT these days because we know that it's been helpful to people before.
Right. It's even a more advanced way of managing pain.
It's more advanced, and we're introducing them to a new approach, an approach that can teach them a new skill set to help them gain greater control of their lives. And we're trying in this initial meeting to assess their readiness to embrace this new paradigm with us, their readiness to change, by seeing if they are willing to suspend disbelief, to examine the possibility of a new approach.
Do you ever bring in the idea that maybe their pain has begun to control their lives to the point that they identify themselves as being a chronic pain patient, and this has taken control over them?
Yes, absolutely. We think about ways of defining for them how pain really has now become a driver of the choices that they make, of the things that they do in their lives, of their relationships, their occupation, their avocational interests. This has become too pervasive, and it's become an identity. And we're trying to teach them a new skill set that will help them to restore a sense of control to a life that right now to them too often feels out of control.
Right. Okay. And do you do that in the context of perhaps when you distinguish nociception and suffering, what we've already covered before, but in that context you could bring in the identity issue, which would lead right into the CBT referral?
No, you're absolutely right. And I think that using the patient's own examples to make that distinction clear and to help them understand that there are aspects of their experience that they can learn to control.
Right.
And that then can help to lay the foundation for referral to a CBT psychologist, and we assess their willingness to accept that referral. And if they're on the fence a little bit, then I think what we often do is we say, well, maybe a trial would be helpful. A trial of 3 or 4 visits might help them to begin to at least explore this new way of thinking about their pain and have a little bit broader opportunity to assess how it might affect their lives.
Great. Thank you, Jeff. I think that's so helpful, and that's such an important part of the pain management process. Would you mind summarizing for our participants in the course exactly what you just explained?
Be happy to. So, what we've learned today is that there are several steps that are part of introducing CBT to your patient. We start first by validating their experience as excruciating and awful for them, and we validate with them that nothing so far has worked to address their pain sufficiently. Second, we distinguish for them the difference between nociception and suffering using their own experiences, and again making the point that so far no one has addressed with them this important distinction between nociception and suffering. Third, we try to assess their willingness to change their way of thinking about pain, to change their paradigm, and embrace a new set of approaches. Fourth, We normalize that CBT represents an advanced approach to understanding pain, that there's strong evidence to support it, and that it involves teaching them a new skill set to help them achieve their own sense of control over pain. Finally, we propose, if they're reluctant to embrace the idea of a CBT referral, we propose a trial of 3 or 4 visits with a CBT psychologist so that they can learn more about that approach and make a more informed decision about whether to proceed.